Good morning. Thank you. When I was asked to give a talk this morning about total joint replacement, I thought about what's had the biggest impact on our patients over the last several years. And I think, as you can see with some of the other talks, that technology has had a huge impact, and that's been ongoing. But we've had a big impact on the clinical side, taking care of these patients, by minimizing the blood loss associated with the surgery. And it's had a dramatic impact on their outcomes. And I looked at a little bit of data before the talk just to see, to check to see if we're doing a good job with that, and I'll outline that as I go along. The problem with blood loss is, in the OR is a big problem with total joint replacement, and it's getting better, but there's multiple issues involved, and the biggest has to do with transfusion. So with a total hip and a total knee, historically, patients required blood transfusion, and it occurred up to 80 to 90% of patients who had a total hip or a total knee needed at least a unit of blood post-operatively. And that's no longer the case, but the cost associated with that, both economically and to the health of the patient, is pretty dramatic. If you have a blood transfusion, it's documented that you have a higher risk of an infection post-operatively. It definitely delays the recovery after the surgery. Results in longer hospital stays, and actually can increase the overall mortality associated with these procedures. So we have a goal here, and that's to decrease the need for blood transfusion in these patients. How do we do that? Well, it starts before bring the patient to the operating room. The patients need to be medically optimized. They need to see their medical doctors. If they're anemic preoperatively, there's different strategies we have to try to improve their anemia and improve their blood counts prior to surgery. And we count on our colleagues in medicine and hematology to help us organize that. In addition, almost all of our patients are placed on iron preoperatively. That's a standard. It's difficult for everyone to take the iron, the side effects of the iron, so we encourage everyone to take it. And it works reasonably well, but the side effects are difficult for some patients. Then within the operating room, we have a number of techniques, and many of them have to do with the anesthesia that we use. If we can use regional anesthetics as opposed to general anesthetics, we can keep their blood pressure lower. And having lower blood pressure at the time of surgery decreases the blood loss associated with the surgery. And in knee replacement specifically, the use of the tourniquet has changed dramatically over the last several years. You would think that using a tourniquet during surgery would actually decrease your blood loss, but the studies indicate that overall patients suffer with more blood loss when a tourniquet is used. So we've gotten away from the use of a tourniquet routinely in total knee replacement. I think the biggest reason it's helpful to stop using it is that you can see the bleeding at the time of the surgery and correct it, as opposed to putting the tourniquet on, sewing everything up, closing it, and then letting all the bleeding happen after the patient leaves the operating room. So we have better control over it. It adds to OR time to not use the tourniquet, but I think it's better for the patients. And there's another device that we're using in the operating room that's proved to be very effective in helping patients minimize blood loss, and that's tranexamic acid, or TXA. And we're using that routinely, or most of us are using that routinely now in total hip and total knee replacement, and that's been valuable. I'll go into that in a little more detail. And the last is how we treat patients after they leave the operating room, the decision to actually transfuse a patient. Years ago when I was a resident, generally if their hemoglobin and hematocrit dropped below 10 and 30, it was sort of an automatic trigger to transfuse patients. That's certainly no longer the case. There was no really good data to indicate that that helped patients, and in some ways it could be harmful. So now we try to use better clinical judgment. There's no hard and fast rules of when a patient needs a blood transfusion following surgery. It has to do with a multitude of factors, obviously what their H&H is, but also what their clinical status is, what their vital signs are, what their physiology is. Different patients can tolerate different levels of H&H and anemia, and you have to keep that in mind when you decide whether or not you should transfuse the patient. TXA, this has been, I think, the biggest difference maker, at least recently, in terms of post-operative transfusion. there's multiple studies available that advocate the safety and efficacy of this medicine. Now, this medicine is relatively inexpensive. It's something that's been used for years, but was not used in total joint replacement routinely until the last several years. There's two ways to give it. You can give it either IV or actually into the joint itself. And studies indicate that they're both equally effective. When you give it IV, you often give a dose right before surgery and then right at the end of surgery. I choose to give it intra-articularly at the end of surgery after the fascia has been closed, but the studies don't indicate a big difference between those two different routes. The best thing about the TXA, it doesn't seem to result in many complications. The data indicates that it's very safe to use, and it's when you first think about how it works, it worries you a little bit. What TXA does is it stops the it inhibits clotting by breaking down, by stopping the process of breaking down clots. And so when blood is clotting, our body has two kind of opposing forces. The blood is clotting, and then the body's trying to break down the clots. And when these two opposing forces are working well, that's normal homeostasis. But post-operatively, there's a tendency for the body to break down these clots and have the bleeding continue. So this medicine prevents the breakdown of the clotting that happens. So you think that could lead to increased risk of clotting, which include blood clots in the legs, pulmonary emboli, strokes, those types of things that are associated with clotting. But the studies indicate that this medicine is quite safe and there's no significant increased risk of any of those types of complications. Contraindications are debated. There are some who feel that any patient with a history of significant clotting disorder, stroke, or DVT should be contraindicated, but there's no hard and fast rules. And I think my feeling is if you're using it topically, the only contraindication would be some kind of allergic reaction to the medicine, which is extraordinarily rare because this isn't a medicine that you would ever see in any other setting. So I looked at this, the data of my patients over the last year or so at Greenwich Hospital, and discovered that my patients received a transfusion rate of about 4% or just under, and that seemed to fit anecdotally when I thought back over the past year. And that's all comers. There's a lot of different patient ages, preoperative conditions in terms of medical conditions, and preoperative anemia. And the number of patients who needed a blood transfusion was about 1 in 25. And when you look at multiple studies, as I did looking at the literature, the rates vary from 11 to 67%. And I looked specifically at Greenwich Hospital at other patients who had not received TXA and some of these other techniques, and their transfusion rate looked like it was about in the 10 to 12% range. So I think that these techniques are making a big difference in terms of the clinical outcomes for these patients, which speeds their recovery and allows them to get up and get moving and feel better clinically following the surgery. Thank you.